think we're very fortunate to have Dr. Yang today to talk to us about healthcare leadership. Dr. Yang.
Thank you. Thank you so much, Jennifer. All right. So yes, I'm a family doctor in Surrey. Surrey's about 40 minutes drive from here. How many people here are from out of town? Where are you from? Nanaimo, yourself? Victoria? Ottawa? Nova Scotia. Welcome, welcome. Disclosures. I've nothing to really disclose. I've moderated a few times for various pharma, and of course that doesn't really matter today. In the next few minutes, know that you are free. You're free to wander around. You're free to go to the bathroom, to stretch, stand up. I'm going to take you through my manic journey through QI these past few years. You're going to look at a few health system dashboards. You're going to learn, I'm going to share with you the lessons that I've learned from some health leaders that I've met. And I hope that you will use some social media today. Because I have so much content, I've left links and I've left the usernames of the leaders that I've met on the screen. Feel free to snap pictures with your phone so that you can connect with them as well to continue your health care leadership journeys. What is the greatest problem in healthcare? What's the greatest problem on the island? Not enough beds? Not enough beds. So that's acute care beds. What are some other? Yes, Nova Scotia.
Nova Scotia's access to doctors.
Access to primary care or any physician, really. Any other problems?
Overuse of pharmaceuticals.
Jennifer said polypharmacy or overprescribing. Physicians not taking the time to consider all the factors before they prescribe. One of the problems one of the key solutions or key techniques that we're underusing in all of these areas that you mentioned is that we don't really have a good awareness of the issues. We're not using dashboards. How we are performing is not common knowledge. How can you expect a team to improve their performance if they don't know where they stand or where they've come from? So Jane Pope called that transparency of metrics, penetration of the current data down through every level of your organization. And there's many ways you can do that. Social media, a whiteboard. My first healthcare leader was this man right here. That's Dr. Kwong Yang. He's my father. He showed me that healthcare leaders improve things by working more, by sleeping less. But he also showed me about the care in healthcare. He showed me that kindness is actually a therapeutic regimen that within research has shown to decrease pain, decrease anxiety, increase wound healing. So I took all that goodwill, the medical knowledge that I gained from medical training, and the leadership from people like Dr. Don Berwick, who told me people don't need technicians, they need healers. So I took all that fervor and energy and passion, and I threw it into the community where I was practicing. I practice in one of the second largest homeless community in British Columbia. Due to our temperate climate, we draw a lot of the people who have to live in tents. This is my clinic parking lot, and there are my patients. So of course, the complexity of the care that I was asked to provide was trumped so much my training. It trumped my fee-for-service remuneration system. It trumped all the resource ignorance that I had. I was not trained on how to access the resources in my community, and that's rarely a part of medical education. So obviously, I became completely burnt out within 2 or 3 years. I was giving and giving and giving, and I wasn't recharging. I didn't know how to reach out, admit that I didn't know what I didn't know, and ask for help. My cynicism increased. I was a less effective healer. And I didn't know that 54% of physicians were in the same position as me. I realized that the heroism that I was going for is out. Because heroism is a story of a single person. What is necessary for healthcare to survive is collaboration and teamwork. It's about humble inquiry. It's about the listening skills that we talked earlier about in Candice Manahan's talk. It's about recognizing that healthcare and quality improvement is all a team sport. A colleague of mine in the States, Dr. Rana Oddish, had her own healthcare and burnout and health journey. And she encouraged me with her words, "Don't let this culture of medicine change who you are. Act bravely and know that you can do better than healthcare. Healthcare is sick. You have the potential to make a difference." I learned from her that admitting my vulnerability, finding balance, and building resilience was a key. I started to research into the history of how our healthcare system got to this position. Can somebody finish this sentence for me? The healthcare system is not broken. It was. The healthcare system is not broken. It was.
Never working in the first place.
It was never working in the first place. It was designed this way. It was designed without the foresight of the demands and needs of the population. Dr. Les Vertesi is an advisor to the current health ministry. And he wrote this book, Broken Promises, which talked a lot about the failures of our current healthcare system. This was published back 15 years ago, but very few people have read it. It's available on Amazon. Coming out of burnout, trying to recover, I reached out to the Doctors of BC, which is kind of like the biggest negotiating body for physicians here. And they have a policy that in their culture, they're there to support us physicians. We pay dues to them, and they make things happen for us. I was open about my struggles with the system. This is Katrina, and she's pointing me in a few directions of where I could learn more skills. Within my burnout, I made many clinical decisions that were not the best. And I did put some patients in some potential risk of harm. But I thought, if I'm not the only one going through this, and I'm in my recovery, I must share my experience. So I began to speak about my struggles with burnout, about my challenges with dealing with mental health and addictions on my own in the fee-for-service system, about the learning curve I had to go on how to prescribe opioids in a safer way, for example. My journey took me to the head of quality improvement in physicians in British Columbia, Dr. Kurt Schmetcher, who you guys met earlier today. He was heading up a project called the Physician Quality Improvement Project. And a few of us in the room today are involved in that. We know that in about 10 years, half of all programmatic spending within our province is projected to be spent all into healthcare. The willingness to throw money into that bucket is because healthcare is important. This is your mom's life. This is rigorous research evidence publication. So there is an assumption that what we're doing in healthcare is efficient by those outside the system. Those of us within it understand the challenges. Dr. Smetcher, this is a driver diagram exercise, taught us about a systems perspective, how to see how one silo impacts another silo, how to bridge those silos, and to prioritize and strategize. Where will you get the biggest bang for your buck? What is the top priority challenge within your system? Using driver diagrams. Some more research. Dr. Smetcher also taught me that within healthcare, you will get opposing opinions frequently. And many strong-willed people within healthcare tend to take those opposing ideas personally. With their filters, they will interpret personal attacks from them, feel that their self-worth is threatened. Most of us would disengage at that point. But the need for the survival of our system requires that all healthcare leaders stay in the conversation. Dr. Smetcher modeled that for me. Mr. Gerald Langley wrote a book called The Improvement Guide. He was friends with Dr. Smetcher. Gerald Langley taught me about how so much of our funds go into putting out fires, throwing good money after bad, potentially. And so little is put into future-proofing our system, into redesigning, into innovation. All of these are available on Healthcare Dashboard, at Healthcare Dashboard on Instagram, as well as Health Dashboard. If you look at the hashtag Healthcare Dashboard. My journey took me to the Patient Safety and Quality Council within British Columbia, the largest quality healthcare organization in our province. I joined the Pink Socks movement. If you don't know what it is, look at hashtag Pink Socks. I joined the Quality Academy, where we learned about how to make teams function better. The CEO is Christina Kraus. If you look her up at CK, Christina Kraus for Quality, CK4Q, you can ask her questions about her experience. She has some of the longest experience as the leader of a quality healthcare organization within Canada. The Patient Safety Quality Council elucidated that some of the main demands of patients, actually asking the patients what's important to them, was that they need to trust their providers. They need to be informed about what to expect in the next step. They don't actually expect us to solve every problem, but to listen. And they want us to identify ourselves clearly. Healthcare leaders specifically train in communications effectiveness. Also through the Doctors of BC, I was afforded the opportunity to do official physician leadership training. This is Dr. Douglas Cochran. I believe he's a pediatric neurosurgeon. Is that correct? Yeah. He's also a leader in the development of quality and leadership programs in British Columbia. He taught me that our strategy for quality has been gravely missing in many areas. We focus a lot on clinical experience, but we do not focus on how to build culture, how to prioritize change ideas, how to design for sustainability, how to measure for improvement. These are things that no one had the foresight to do until recently. Dr. Cochran led one of the sessions at the leadership training, and he said very clearly, for every one of us in healthcare, our job is change. The ownership of our current healthcare crisis ideally should be owned by political leaders, physicians, universities, and the public. But currently, according to thorough research, physicians don't see what they can do about it, so they disengage. Universities don't feel that they have the clout, and the public is generally distracted. A physician leader, Dr. Ken Jeong, reminded me that I am to be the change. I met Dr. Susan Shaw, who's the Chief Medical Officer of Saskatchewan. She taught me that leaders make a map of influencers when they're trying to lead a change project. Networking is critical to an effective health leader. Identifying who are the influencers within the radiology department, who are the influencers in the division of family practice, who are the influencers within the triage at the emergency room. Bringing together a multifaceted team is critical. Wellness, of course, needs to be a priority. At one of the quality forums earlier this year, I met a man named Michael West. He comes from an organization called the King's Fund in the UK. In a Commonwealth analysis, the UK's health system was identified as one of the top functioning health systems in terms of access and equity and some other metrics. He reinforced what we already know, that building trust on a team unlocks cycles of compassion. So building trust is key. He's on Twitter at WestM61. An effective healthcare vision, a leader will be able to transmit that within 20 seconds. Earlier, Jane Pope showed us a 1-second version. Does anybody remember what her effective vision for the Hill County Medical Center was?
Remarkable.
Say it again.
Remarkable always. Yeah.
Remarkable always. Some teams will need a little bit more vividness to help them guide their decisions. Vision should be daring as well. They should match community needs. Good healthcare leaders prioritize psychological safety. Intimidation. In research, thorough research done, this is actual research now, by the King's Fund, shows that intimidation or psychological unsafety or unsafe psychological situations are as risky as medication errors or infectious disease. These are some of the don'ts of healthcare leaders. Gossip, complaining, and what I call blame throwing are ways to degrade and erode trust within your system. Has anybody heard of Helen Bevan? Who is Helen Bevan? A key leader in quality improvement in the UK. And she's probably the most influential healthcare leader in the Twitter sphere. At Helen Bevan. She taught me a lot about how a good leader grows others. A good leader is someone who develops others in their leadership capability, who recognizes if someone is having challenges leading themselves, and will grow them and give them freedom to explore and innovate. She showed me that even though we know that so many people spend hours on Facebook, Snapchat, and Instagram, the top 3 mobile apps, constantly, that these apps are not being used for healthcare literacy at all, not being used to modify the public's behavior in the utilization of our scarce healthcare resources. Instead, the public is inundated with cat videos, Videos of people failing. Oh my gosh, somebody give him a napkin, he's joking. Or how would
Very well timed.
My journey took me to Boston. In Boston, I met with Dr. Don Berwick, one of the most inspiring healthcare leaders I've ever met. His mandate is about compassion. His mandate is about strategy. And it's about the quadruple aim. About healthcare leaders having a balanced aim between people, process efficiency, and healthcare performance. The health of patients and the health of providers are one and the same, as Jane Pope said earlier. The quadruple aim, many of us are aware of it, but our execution is shoddy. I became a certified improvement coach in Boston, and it was time to apply what I learned. Up to now, it had been all theory. This was June this year. So, in the hospital, we know that communication is so hard. Physicians are running here and there, saving lives. They're not ready to stop and invest time in reflection and replanning. They don't see, historically, there has been nothing productive coming out of many of the meetings they've attended. They have been traumatized by some of the ineffective leadership that has occurred in the past, and they have been traumatized by the design of the system. Our system that has lagged behind the needs of the growing and advancing, evolving population. Our staff's ability to safely feel safe in saying, I don't know how to do that, can you show me how? Actually, I don't know where that is. Can you remind me how we treat that? These questions are not safe questions in the current average hospital environment. Neither are they in the community. People are struggling with problems, and instead of reaching out for help, they keep it to themselves, and the patients suffer. Good healthcare leaders know that prioritizing psychological safety enables patient safety. Healthcare leaders know that the capability of a system is directly related to the organizational culture. How does a leader build trust? We talked about this earlier in one of the earlier talks. But it's about expressing your vulnerability. I don't know how to do that, but let's sit down together. I'm sure we can come up with something together. Wishing people well, genuinely, and I remember in your comment, if people don't wish people well, they're not going to change. There is, I believe, there is a value selection process that needs to happen when we choose or appoint leaders. And those leaders who are not ready, but who have the correct values for your organization, we must identify them and grow them and support them. Being ready to do what you say. There's nothing more trust-breaking than asking people to do something, promising an outcome, having it fall through, and not following up. Mistakes will happen, as Ms. Pope said earlier, but we always have an opportunity, if we are not afraid, to re-engage. This is the hospital where we're trying to improve our practice. We work in such a complex system. Our hospital was expanded about 5-6 years ago. All the divisions are disparate, siloed, not really connected. The problems seem so complex and overwhelming. Leadership is trying, but we don't have the penetrance to get into the teams, to encourage them and to build their courage and to build the team yet. One of the courageous hospital leaders is Dr. Marietta Vandenberg. She embraces complexity, which is something that every healthcare leader must do, to be able to balance and intake and process multiple variables at once, and to push people to do this for the people, for ourselves, for the patients. Trying out and practicing some of these techniques, cultural safety techniques, our hospital with Dr. Vandenberg as part of the leadership, were able to prioritize innovation and provide some experiences. In this picture, Mr. Jim Clarkson was able to get a visit with one of his horses, even though he was very sick. Infectious disease safety were taken into account. A tent was put up, and he was able to visit. Healthcare leaders value and recognize the importance of supporting second victims, those victims of a tragedy within the hospital, where you witness bad outcomes. Healthcare leaders value mindfulness, as mentioned earlier, and strategize for wellness. If we notice that there's a department that's particularly short, call schedules are getting Q1, Q2, there must be some type of strategy for that. Historically, we haven't been using some of those predictive models for supply and demand. And that's harmed us. But going forward, our system must adapt. Schwartz rounds is an idea that's being floated around that may be an answer to increase some of the psychological safety and some of the wellness, where healthcare workers can come together and share some of their negative experiences and have an avenue for support and expression of their challenges. But what about where I spend most of my time? In the healthcare outpatient area. Family physicians are expected to run complex systems with high volume. And their business leadership and training skills are near nil. Where was the strategy in that? Thankfully, the Doctors of BC is revving their engines as much as they can to send out practice support teams to try to assist clinicians with improving their business efficiency. Every one of these business efficiency challenges impacts significantly the delivery of our healthcare and increases the costs when they're inefficient. We've been given a mandate to design primary care networks. Most family physicians have not taken the time to step off of the rat wheels of work to actually analyze and see what that actually means. Their confidence is very, very low in how to do that. How can we build that confidence? It comes through engaged leadership. Traditionally, healthcare organizations, health authorities, they know some of these truths about a clinician's training in project design, in project management, in design thinking, these gaps in the training that physicians have. So their trust in partnering with physicians becomes very low. They've had experiences where they partner with physicians, and instead of innovation, instead of openness and listening, all they feel is the ego, the physician ego, which has become a barrier to progress. Physician leadership training can make an impact there. Physicians themselves, their levels of trust. We require high levels of trust for effective healthcare teams. But their level of trust for their direct clinical care team members is not that high. Their trust of clinical leaders within their organization who are one degree of separation removed is even lower. Their trust of their own division leaders is further lower. Their trust of other doctors is potentially further lower. Their trust for political leaders is further lower. How can we build this? I propose that the physician leader development is probably the only way. Through developing peer leaders, that's the only way that we can change some of this and build it. So, continuing studying, in the outpatient, I needed to test some of my leadership skills. I decided to follow the textbook on quality improvement and engage a patient voice. Adrian, who's agreed to, this is from an article that was published by the Doctors of BC. We sat together to try to plan around a project about frail seniors, how to reduce the unnecessary usage of acute care services. We remembered from our leadership training that productive healthcare teams are aligned in their values. They are empowered. They have 5 to 12 members. There's a diminishing returns after you get beyond 12 members. The goal clarity and role clarity is vivid. They have protected time, and part of their aim is to cross the silos. We were able to eventually put together a fantastic multidisciplinary team. We have data analysts, we have evaluators, we have nurses, medical office assistants, physician, patient voice, division membership, project managers, technology specialists, and we were able to get good progress. We were able to run a pilot which showed that we were able to reduce emergency room use by about 50%. By repositioning an already employed nurse and expanding the scope and supporting her in her mobility to interface directly face-to-face or by cell phone with the physician and the patient, instead of waiting for a fax machine to pop up, not having a relationship to leverage for efficiency of services. The opioid crisis. British Columbia has been in a state of emergency for 2 years regarding the opioid crisis. 1,400 people died last year from fentanyl. None of them, by the coroner's reports analysis, had buprenorphine in their system. I saw an opportunity to bring physicians together using techniques of due process, engaging the right size of teams, convincing them, sharing a clear vision that we were going to make an impact on the opioid crisis. They had never considered prescribing opioid agonist therapy in the past. But because of the engaged leadership, because of the messaging, because of the caring about them, building in the due process, having the vision in my mind, but not saying it out of my mouth, evoking it from the team members, putting it on a board, I've been able to grow a team of just 1 to 10 providers. Each one of these physicians could potentially save some lives, give someone's nephew, someone's cousin, someone's son another chance to recover. 4 million. 4 million patients, 4 million Canadians want to have a physician, but do not have one.